Hi, today I'm going to talk about an Insulinoma patient. So let's begin. We have a 55 years old female, and her main complaint was her husband saw that she was having a seizure while she was sleeping at 1 p.m. So, in her medical history, we see that she was having the same symptoms for the last 12 years, and those symptoms occurs 5 to 7 times per month, and they usually occur like they cause sweating, they cause feeling generally unwell, and sometimes they might they might cause um, partial amnesia. So in her past medical history, we can also see that she was diagnosed with epilepsy 12 years ago. But then, in the last year, she went to a neurologist, and that neurologist changed her diagnosis to dissociative disorder, which is a psychiatric disorder. So now we see that our patient is having seizures. So let's take a look at seizures. So we divide seizures into two subcategories. First one is focal and the other one is generalized. In focal seizures, we see that. Uh, Wait, first I need to describe a seizure. So usually, our brains our brain waves are not synchronized. But in epilepsy, from a one focus, they start to become synchronized. Okay, so if it only affects one lobe of the brain, we call it focal. For example, if it only affects to temporal lobe, the patient might have some smelly symptoms, odorous symptoms, for example, smelling bad or smelling good. Okay, or if it happens in the occipital lobe, patient might see some hallucinations. Okay, so that was focal. But if it affects all part of brain, so we call it generalized, and we also divide it into two subcategories. First one is non-motor, which is also called absence. In absence non-motor seizures, patients stop what they do, okay, then stare somewhere else for less than 1 minute, okay? They do not usually remember it. In motor generalized seizures, we have four subtypes: atonic, tonic, myoclonic, and clonic. In atonic, patients lose their tonus, muscle tonus, and they usually fall. In tonic seizures, they have increased level of tonus. It's like in what was that disease? Tetanus. Yeah, it's like tetanus. In myoclonic seizures and clonic seizures, patients have jerking-like movements, but in myoclonic, those jerkings are smaller compared to clonic ones, so it's more like a twitching in myoclonic. Okay, in clonic we have jerking movements, so we can say that not cannot say that right now. So if you ask the patient's husband what kind of seizure that she had, of course he will not say that she had some clonic tonic movements. So her husband said that she was moving her hands and arms repetitively. So we can say that she's having clonic seizure. Then, back to the patient, we measured her plasma glucose levels and it was 2.5 millimole per liter. And also it is equal to 37 milligrams per deciliter. If you want to convert millimole per liter to milligram per deciliter, you need to multiply it by 18. Okay. So, in hypoglycemia, to define hypoglycemia, we first need less than 3 millimole per liter plasma glucose and 55 milligrams per deciliter plasma glucose. Less than 55. But this is in normal patients, okay? In diabetics, it's an extra information, but I just want to give it. Diabetics, it's less than 70 milligrams per deciliter, okay? It's not about our case for now, right now, but I just wanted to give it. Okay, in hypoglycemia symptoms, we divide them into two: autonomic and neuroglycopenic. In autonomic, patients might have sweating, feeling hungry, tremors. It's because of adrenergic response. Okay. Neuroglycopenic symptoms, it's because of low glucose intake of neurons. Patients might have dizziness and altered mental status. And let's continue with hyperglycemia causes. We usually divide them into two: fasting and non-fasting. In fasting, we have with hyperinsulinism and without hyperinsulinism. If you look at with hyperinsulinism, we will see, firstly, we need to ask if the patient use oral antidiabetics or insulin, because they may you Let's continue with hyperglycemia causes. We divide them into two: fasting and non-fasting. In fasting, we have with hyperinsulinism and without hyperinsulinism. If you look at with hyperinsulinism, we will see oral antidiabetic or insulin overdose. We first need to check this first, because patient might have some psychiatric disorders too, and maybe she or he tried to suicide or else. And we also have autoimmune hyperglycemia. We divide autoimmune hyperglycemia into two: type 1 and type 2. Type 1, we have autoantibodies against insulin, and those antibodies bind to insulin. So if you eat, your plasma glucose levels will increase, right? Then you will secrete insulin, but those insulins will bind to autoantibodies in your body, so they will not affect your plasma glucose levels. So your pancreas will work harder to compensate high plasma glucose levels, and eventually it normalizes plasma glucose levels. But then, since the autoantibodies have low affinity to insulin, they dissociate and you will get free insulin, but now your plasma glucose levels are normal. So you will have high insulin and normal plasma glucose, so it will decrease. In type 2, you will have an autoantibody against insulin receptor, and they might act like insulin, or they just block insulin's action. So the mechanism is not well understood, but for example, if you have a type 2 diabetic patient, and if you cannot treat her, so you need to resistant type 2 diabetic patients, so you need to first check this one: type 2 diabetics, the type 2 autoimmune hyperglycemia with decreased insulin action. Then we will have pancreatic beta cell tumors, which are also called insulinomas. Insulinomas are neuroendocrine tumors, and they originate from beta cells. I wrote a question mark over there because in UpToDate there was an article which said that they can also be originated from ductal cells. The incidence rate is 4 million per year. Female to male ratio is nearly 1. 25% of the patients diagnosed as a neurologic disease or psychiatric disease. They are usually small. They are usually less than 2 centimeters, and they are non-malignant. Their malignancy rate is 10%. So for diagnosis, we need to check insulin levels, C-peptide levels, and IGF-1 levels. We need to find high insulin, high C-peptide, and low IGF-1 levels. And we can also have some tests for diagnosis, which is 72-hour fasting test and calcium stimulation test. So in 72-hour fasting test, patients cannot eat anything for 72 hours. So test begins at the beginning. So we give them a cup of water with sugar and the test starts. So if plasma glucose levels drops below 50 milligrams per deciliter, or patient show symptoms of hyperglycemia, which I told just here, those autonomic or neuroglycopenic symptoms. So we need to finish the test. Just before finishing the test, we need to take a blood sample. That blood sample is the most precious blood sample because it will guide us to the diagnosis. So in that blood sample, we need to find high levels of C-peptide and insulin, and low levels of course, plasma glucose and beta-hydroxybutyrate, because insulin inhibits beta-hydroxybutyrate synthesis. So beta-hydroxybutyrate is a ketone body which we produce when we have low levels of plasma glucose. Like for example, in diabetic ketoacidosis, you will have less insulin, so it will lead to increased ketone body production. So in calcium stimulation tests, it's more like a test for detecting where the insulinoma is. So we have 3 separate arteries: splenic artery, gastroduodenal artery, and superior artery. At first, we give splenic artery calcium gluconate, and we also have a catheter placed in the hepatic vein which detects insulin. So normally when we give calcium to normal beta cells, they do not produce insulin, but in insulinoma cells they do produce insulin. So for example, we give calcium to splenic artery and it's secreted in insulinoma cells. So in the tail of the pancreas, we can say that we have a insulinoma, just like that. So, and also in chronic renal failure due to the decreased insulin clearance. So for example, if you have a type 2 diabetic patient which has normal values of hemoglobin A1C, you need to be cautious about chronic renal failure because they can also cause hypoglycemia. And if you look at hypoglycemic causes without hyperinsulinism during fasting period, you will see alcohol consumption. Alcohol suppresses gluconeogenesis, so you will not produce glucose when you are hungry, so you will be hypoglycemic. And we also have hypercortisolism. It may be due to hyperpituitarism or adrenal gland insufficiency. And we also have non-pancreatic tumors. It has an interesting mechanism behind it. So we have normal IGF-2, right? It binds to IGF binding protein 3 and becomes active. But if it binds to ALS, acid level subunit, it will become inactivated. But in non-pancreatic tumors, they produce big IGF-2s. Those big IGF-2s also bind to IGF binding protein 3 and they become activated, but they do not bind to ALS subunit, so they will not become inactivated. So they will act like insulin and they cause hypoglycemia. In non-fastings, we have non-insulinoma pancreatitis syndrome. Those patients have hypertrophic, I cannot write it, no, I forget how to write it. Anyway, hypertrophic and hypertrophic nesidioblast cells. So they will secrete more insulin. So let's have a look at hyperinsulinism treatment. But first, we need to treat hyperinsulinism without hyperglycemia symptoms. Okay. If your patient have hyperglycemia symptoms, then you will need to first give glucagon and at 25 grams IV, 50% dextrose solution first. Those treatments are for non-symptomatic patients. Okay, we can suppress insulin release by insulin releasing inhibitors, for example, diazoxide. Diazoxide activates or stabilizes potassium channels. So we have a potassium channel right over there, this channel. So normally your pancreatic beta cells produce ATP from glucose with oxidative phosphorylation. Then those ATP binds to sulfonyl receptors, or here 6.1, not receptors, they are proteins, potassium channel proteins. Those ATPs will bind to them and inhibits that potassium channel, so it will not work. So your beta cells will be depolarized. Those depolarization cause calcium influx into cells, to cell membrane, and those calcium influx will cause insulin release. But if you stabilize those potassium channels, your cells will not get depolarized and will not secrete insulin. We will also have somatostatin analogs because insulinoma cells express somatostatin receptors. And we can also use calcium channel blockers. And the primary treatment is surgery. So let's back to our patient. Our patient, we had a 72-hour fasting test to our patient, and she ended our test at 40th hour. We took a blood sample, and we found that insulin and C-peptide was increased, and beta-hydroxybutyrate rate was decreased. So we thought this patient had an insulinoma. We also need to check type 1 autoimmune hypoglycemia. We also check that for autoantibodies against islet cells or against insulin. Okay. We did an MRI, and MRI showed us 4.1 centimeter large grade 1 tumor, and we did a surgery to the patient. And now patient is healthy after 12 years. So that was all. I hope you liked it.